Obesity Surgery and Devices Part 2 lecture. Liposuction is a procedure that's known as a cosmetic surgery that a lot of Americans have used over the past few years. Liposuction involves using a thin vacuum-powered tube known as a cannula to remove fat through a small incision. One method also uses ultrasound energy to dissolve the fat before it's sucked out. A single procedure can remove millions of fat cells, and once they're out, they're out. But if the individual gains weight later, then the fat will be stored somewhere else where there are fat cells. Now, the operation is painful in a couple of ways. One, the patient can expect to have bruising and swelling that can last for 2 to 3 weeks, at least. It may last longer. And then numbness in the treated area, and that may also last longer than the 2 to 3 week period following the procedure. The patient may also have to wear compression garments for several weeks as well. Here's an illustration of the liposuction process. So notice the example of the skin with the dermis and the subcutaneous layer on the left-hand side. A cannula has been inserted, and then it gets moved back and forth, and fat cells are sucked out of the subcutaneous layer, causing the subcutaneous layer to be decreased in terms of its depth. So the tissue on the right-hand side reflects those changes. One of the challenges with this is that depending on the amount of fat cells being removed, there may be a big amount of slackness within the skin. Now, the illustrations in the upper right-hand side of this illustration reflect areas that are suitable for liposuction. It includes on the face, the cheeks, the chin, within the upper body, the axillary region, the inferior aspect of the arms, then anterior abdomen, lateral hips, okay, within the inner thighs, as well as around the calves and the lateral thighs. Here's a photo of a patient receiving liposuction. Please notice the individual on the left side of the photo that's holding a container. That container reflects the amount of fat cells that have been removed from the patient at that point of the procedure. Risks that are associated with liposuction include infection, bleeding, pulmonary embolism, anesthesia complications, asymmetry, uneven contours, and permanent weakness. Now, since this is a cosmetic procedure, insurance companies generally do not pay for this. The cost is anywhere from $2,000 to $6,000 per procedure. Now, it's important to understand that liposuction does not improve the patient's overall health. That is only possible if the patient loses weight through diet and exercise and/or surgery with this process. Some liposuction procedures can remove up to 22 pounds of fat, but the loss has no bearing on the patient's metabolic risk factors for items like heart attack or stroke, or blood pressure issues, or cholesterol, blood sugar. It's not the number of fat cells in your body that affect a person's cardiovascular risk. It's the amount of fat that's stored in those cells. The bigger the cells, the greater the risk. It's important to remember and understand that this procedure, liposuction, removes the fat cells. It does not shrink those fat cells that remain. Lipodissolve is another procedure for removing fat. It's also known as mesotherapy, lipolysis, injection lipolysis, or lipostable. This is done in different types of centers throughout the United States and in other countries of the world. Lipodissolve is a process of injecting the patient with a chemical mixture that includes PCDC, and this is phosphatidylcholine deoxycholate, and this mixture is injected into the targeted treatment area. Now, PCDC is approved by the FDA for breaking down blood fats that may increase the risk for heart disease. It has not been FDA approved for injection or any other purpose. When it comes to the mixture that is used for this procedure, there is no standard ingredient list. And though some ingredients may have been FDA approved, like the PCDC, for other uses, the mixture itself that's used for this procedure has not been FDA approved on its own for this procedure, nor approved as a mixture. So what's been found is that with this procedure, the fat cells will absorb the PCDC. They become slightly inflamed, and then they begin to harden. The hardened fat cells then begin to break down within a few weeks, and they're going to be excreted as waste products from the body. Now, individuals may require anywhere from 1 to 6 sessions to be performed depending on the area that they're having treated. And once the fat cells are gone, they are gone from that area. All right, but they may have to go back over a period of time to get rid of additional fat cells that the original treatment may have missed. Now, once the fat cells are gone, the skin will tend to be more slack and saggy in that area. The cost for lipodissolve can range anywhere from about $500 to $1,500 per treatment. Again, the procedure itself has not been FDA approved currently. Here's a picture of administering the PCDC mixture into the patient. Bezoars. Bezoars are defined as tightly packed collections of partially digested or undigested material that is unable to exit the stomach. Now, the development of bezoars will often occur in patients with gastroparesis, where we have that abnormal gastric emptying. It can also be linked to following gastric surgery in terms of its development. Now, many bezoars are asymptomatic, but some of them can become large enough to produce symptoms of gastric outlet obstruction, where the patient will experience fullness, nausea, vomiting, abdominal pain, and even possibly GI bleeding. Once this condition is diagnosed, treatments include initially trying to dissolve it enzymatically. If that doesn't work, it may need to be removed through endoscopy. And if that's not feasible, based on the size of it, then surgery is the final treatment option. There are 3 types of bezoars: a phytobezoar, which is partially digested vegetable matter; a trichobezoar, which is a collection of hair, so basically it's a hairball; and then a trichophytobezoar, and this is where there's a combination of both hair and vegetable material in a fiber ball. Here's an example of a phytobezoar. Here's an example of a trichobezoar. Check out the size of it, and notice that in order to remove this from the patient, they have had to perform abdominal surgery because of the size of this. Here's a close-up view of a trichobezoar. Foreign bodies. Foreign bodies are defined as the swallowing of things not meant to be swallowed. A variety of foreign bodies may enter the GI tract, and indigestible objects may be intentionally swallowed by children or demented adults. Also, denture wearers, the elderly, and inebriated people are prone to accidentally swallowing objects that may get lodged in the esophagus or the stomach. Now, many of these will pass spontaneously, but some will become impacted, causing perforations. Nearly all impacted objects can be removed endoscopically. However, Surgery is necessary for about 1% of ingested foreign objects. The most common site of impaction is the esophagus, and this is in 75% of cases. Now, with esophageal foreign bodies, immediate endoscopic removal is required for sharp objects, coins that are in the proximal esophagus, and any obstruction that's causing significant symptoms. Now, small batteries that get lodged in the esophagus may cause direct corrosive damage, as well as low voltage burns and pressure necrosis. So these are going to also require prompt removal. Now, other foreign bodies may be observed for anywhere from 12 to 24 hours to see if they will pass through the esophagus. So, looking at gastric and intestinal foreign bodies. Most foreign bodies that can pass through the esophagus are asymptomatic unless obstruction or perforation occurs. And what's been found is that 80 to 90% of all foreign objects that can reach the stomach can typically pass through spontaneously. Less than 1% of them will require surgery. On average, though, objects that are larger than 5 centimeters by 2 centimeters, so basically 2 inch by 1 inch, they're going to rarely pass through the stomach. Also, sharp objects, they should be retrieved because up to 35% of them will cause intestinal perforations. Now, somebody managed to swallow a toothpick, all right, or a toothpick tip. Toothpicks tend to remain within the GI tract wall for years, and they may turn into granulomas or abscesses. Also, if a person begins developing sudden excruciating pain during defecation, that should actually arouse suspicion that there could be the presence of a penetrating foreign body that's lodged in or just above the anal rectal junction of the rectum. Now, again, small round objects like coins can be observed. The patient's stool should also be searched for the object so we can verify it's been passed out of the body. X-rays should be taken to observe the progress for every 48 hours. And if coins remain in the GI tract for more than 4 weeks, then they will need to be removed. So let's move into 8 characteristics of abdominal pain and how this may reveal the pain origin. So when focusing in on abdominal pain and the pain characteristics and how they might help identify the origin of the pain production, please keep in mind that what we are covering is what are the most common scenarios. This is not the typical presentation in every single patient, and there can always be exceptions to the rule. So in general, we're going to start with looking at the onset of the pain. When did the pain begin? And we're going to look at parietal pain and visceral pain. So parietal pain, which is also known as muscle wall pain, tends to be precisely timed. So typically the patient can usually tell you exactly when it began. Visceral pain, which is also known as organ pain, tends to be typically more vague, and it's also typically less precisely timed. So the patient may not be able to tell you exactly when it began. Quality of the pain. How does the pain feel? Typically with parietal pain, it's typically described like sharp or stabbing or possibly shooting. Okay? Again, with parietal wall pain, this is pain that's designed or designated to the wall of a body cavity or a muscular type pain. All right? Muscle wall pain. If it's visceral pain, that's more typically described as being a cramping type pain or a gassy pain or a pressure type pain. Third characteristic is intensity. How severe is the pain? Is it constant? Is it intermittent? With the intensity. So with constant severe pain, that typically suggests a parietal presentation, a muscle wall presentation. So examples would be things like peritonitis or maybe an intestinal infarction. Visceral pain, again, is more typically described as being an intermittent type pain more of a crescendo-decrescendo pattern that suggests, again, organic origin. Now, rhythm, we're looking at a couple of things here. Number one, does the pain come and go? If so, how often? Now, when we're linking this to the GI tract specifically, if you think about it, abdominal pain that's occurring like 5 to 10 minutes and in a very cyclic pattern will often suggest maybe small bowel peristalsis issues. If it's occurring every 10 to 15 or 10 to 20 minutes, same presentation but for a longer time period, I'd be thinking more of a large bowel or colon problem. If we have nighttime pain in terms of the rhythm, when does it occur? Time of day. Nighttime pain could be linked with ulcers, for example. Also, if we're dealing with a female and she has it only once a month within a 1 day or a few day period, we've got to be considering something like maybe endometriosis or reproductive issue. Another characteristic to consider is the pain location. Now, with parietal pain or muscle wall pain, most patients will perceive it quite precisely and can usually pinpoint to where the location is. Visceral pain tends to be more diffuse, and it may be difficult for the patient to pinpoint a specific location or locations. Also, we have to look at pain referral. Keep in mind, we may have the pain being perceived in an area different from where it's originating. So for example, with gallbladder pain, you may have right shoulder pain. Urethral pain, we could have it referring to other areas like up into the groin. So we've got to keep those things in mind, that there could always be a possible referral pattern. Also, cardiac pain, pancreatic pain, esophageal pain, lung disorders could actually produce radiating upper abdominal pain depending on their presentation. So we've always got to think about, when we're looking at pain, can it be referred, or are we looking at a localized presentation? Next characteristic after pain referral is relief. What are the items or the activities that improve or remove the pain? So for example, if they tell you relief or improvement from pain occurs after they eat, well, it may indicate something like ulcers. If they get relief or improvement from their pain with defecation, well, maybe they've got a colitis, and when they empty the bowel, it decreases the pain. If they've got something like a perforated ulcer or a pancreatitis, you're going to find that the patient will tend to stay seated, leaning forward. They avoid maybe laying down. They get into an antalgic position and they are not moving. Also, with something like an appendicitis, you may notice that the patient takes shorter steps with the right foot to avoid decreasing the extension of that abdominal region on the right side, as an example. So what we find is that with parietal or muscle wall pain in general, the patient will try to avoid provocative movement. Okay? They'll try to avoid whatever it is that makes the pain worse. Now with visceral pain in general, position changes don't help. So there's not a lot that helps them to relieve that. And then the final characteristic that we have to look at with abdominal pain is, are there other complaints present? For example, are they maybe dealing with a GI disease? Do they have things like weight loss, unintentional weight loss? If so, I'd be concerned about a possible cancer, for example. Do they have anorexia, nausea, vomiting, diarrhea, constipation, bleeding? Looking at those cardinal symptoms and signs of GI pathology. We also have to consider, maybe they've got a urinary disease. Do they have things like dysuria, painful or difficult urination? Are they dealing with chills, fever, possible urinary frequency or hesitancy? Or maybe they can't urinate at all. So we need to ask about changes in patterning. And then the last component of associated symptoms you want to pay close attention to with abdominal pain would be gynecological diseases, especially with females. Do they have irregular or painful menses? Or maybe they have absent menses? Or maybe they're having an abnormal vaginal discharge? Or maybe they're having dyspareunia, pain with intercourse? So we need to ask those questions and consider the fact that Associated symptoms may help direct us to what the etiology is.